Thanks to each of you for your wonderful perspectives and very informative presentation of the issues that were raised at the workshop, as well as a variety of other issues that need to be borne in mind moving forward. We clearly heard reinforcement of the fact that the work of the committee as it's formed will need to be meaningful, important, and comprehensive. We also heard reinforcement of the importance of the drill down on how issues like equity and disparities, risk adjustment, definitions, fit for purpose will be engaged, and alignment with practices, alignment with the infrastructure capacity, alignment with more granular sets of measures, alignment with other activities, whether it's at the state level or with other sets. One of the issues that each of you mentioned in some fashion that I'd like to lead off the questions with, and I emphasize that we're now opening it up to all of you for questions. But while you're formulating your questions, as well as questions being formulated by those who are watching on webcast, each of you mentioned future orientation in some fashion. And it's very clear that whatever is identified in the way that core metrics are put forth and they're governed and they're dynamic and flexible to engage the changing scene, there has to be some future orientation. Could you elaborate a little bit, each of you in turn, maybe beginning with you, Helen, about what your counsel would be to the committee or any other organization which is involved in measurement development as they develop their own recommendations and ensure that they capture that future orientation in what they're doing?
It's a great question. I'll start. I think that there are a couple of different ways to approach it, frankly. I think one concept is to begin with where you are now, at least in terms of the measures you have now, and then re-envision how that could be measured in the future. And that's part of what the approach, at least for buying value, has been, saying here's a common set of measures. The majority of them are claims-based measures for now, but fully half of them are part of meaningful use. So there's a trajectory going forward that gives you a sense that those are still the right important concepts. They're just not quite ready in terms of data infrastructure yet, but keeping an eye on which measures can move in that direction. And secondly, I think also just being very thoughtful and creative in addition to that first strategy of saying, where are those really high priority gaps? We don't yet have measures, but at least begin to go back to the concept of roadmap to think about what would need to happen to our data infrastructure to allow us, for example, to pull in measures of patient-reported functional status at time zero and follow-up after a procedure, or what would allow us to pull in the voice of the patient completing promise tools online. So I think kind of going from both sides, going from what we have now and thinking about the data infrastructure to move it to a different place at the conceptual level, but then also thinking about at the data level, if you really kind of blue sky it and say this is what you really want, what's the pathway towards getting those data in place?
Thank you, Helen. David?
Oh, yeah, I'm really bad at this. I think I'm going to emphasize sort of the cultural part of it. The first thing is you have to have a sense of the future, and that's something that you're going to think about as opposed to what's happening every day, and that you know what you want to accomplish. That may vary given the measurement feedback, but you know what you want to accomplish. Because in all the remarks that we said today, because I think all three of us have had to struggle with this, is this represents a cultural change, and people being able to decide they're going to give up this measure or this particular definition of a measure that is so close, but it's mine, and we're going to re-look at this again. And secondly, we're going to share in its developments, and thirdly, we're going to share in the results. And that is a huge and very important part of the future. And none of us feels that we can go ahead with developing data warehouses or metrics and so forth without also at the same time developing the culture and that relationship. That's it.
Thank you, David. Kevin.
So I would say that the first thing is to move to patient-centric measures. And what I mean by that is that the unit of the patient or the consumer moves through all of the places we measure seamlessly. So as a person, I could know what my healthcare is, whether I'm in long-term care or I'm in a community health center or I'm in a hospital or I'm somewhere else. I'm the same person, and my diabetes is the same all the way through, and what I expect from my outcome of my care is the same wherever I go. And then that can be rolled up at all different places, but that is what I expect as a consumer. And consumers are expecting that interconnectedness, and so that's the future that we need to have for measurement. I think that also is going to take into account I want to know what others who had the same experience, what their outcomes were, and I need to be part of deciding what those things are. And what we find when we engage consumers is they sometimes have a different idea of value than we do as providers. The story I gave is my brother, who's a type 1 diabetic, and a really smart software engineer. I said, so hey, Todd, I'm working on quality measures, and what kind of measures do you want about your diabetes? He said, well, I know how to take care of my diabetes. I want to know which of my doctors gives me the lowest out-of-pocket cost for any given year, because I have a health savings account, and I need to plan my budget for my health savings account, and which one of these is going to give me the best care at the lowest cost. So we need to find that consumer perspective, build to that consumer perspective, and those are future measures. We also need to use data that really matters for the measures that we need. I think if we would propose measuring the financials of our health system using only clinical data, the financial people would laugh at us. They would say, are you crazy? You're going to use lab results to tell me how much the health system cost? And we need to say the same thing back to when people say we want to use financial data to tell us what the clinical care of the country is like, because it's not built for that purpose. So we need to make sure we have a measurement system that's built for the purpose that it's working on. I think the final thing is a thought about balancing measures. A lot of us have worked in organizations that think very carefully about kind of measures that are partners, and so that you make sure that you don't sub-optimize one part of the system for another part of the system. So as we measure efficiency, we in parallel measure care outcomes to make sure we don't sacrifice any of our high-quality care outcomes with our drive to efficiency.
Thank you, Kevin. Helen, you want to follow up on that?
Just one point in addition to the consumer perspective. I think the thing we often also miss is the perspective of those already in leading healthcare systems who have figured out which measures actually are the future, but they have only never lived outside of their own domain. And I think the question is, how do we sort of view that as a prototype and kind of bring it to scale and say, this is a measure that's worked in this health system, and it isn't just that it's implementable, it has moved the needle on outcomes, it has improved care, and take that as the substrate on which we then build the national measures, as opposed to this always starting from scratch as if nothing had ever been done in the field before, which we do a lot.
Thank you. Let me point out that there are microphones on either side if you'd like to come to the microphone to ask a question. There are also, I believe, is there a wireless microphone somewhere if we need it? I'm going to ask Peter if he has any questions he'd like to pose to the panel. And also Medina, from the perspective of the AMA, if you've got some issues you'd like to raise. And maybe Maggie, from the perspective of the work that you're doing with patients that you've heard about. Maggie Carey, Medina Wilson, and Peter Long. Are there any questions that people would like to raise before we turn to these folks? Yes.
Hi, David Nielsen, otolaryngology, head and neck surgery. Helen, thank you very much for your comment about denominators matter. And I think I want to link that to some of Kevin's comments too. Every once in a while as we go through this, I think we need to pull out that one pager that you referenced at the beginning that sort of takes us back up to the 70,000 foot view and talk about the little sense of priority. We all have this incredible sense of urgency. And our priorities depend on whether or not the moon is full or who we happen to be talking to on that day. So if we're looking at core measures and their critical importance, then there's a tendency for us to abandon the need for the specific measures that are really relevant to the individual providers. To Brent James's comment, if we get really focused on the outcomes and we forget the processes that led to those, we can come up with results and data, but no idea how to manage them. Trying to aggregate the demand and then to unify our response will only take us so far, and I think that's where many of the physician societies are, and it's too confusing to them. So we have endless conversations about exclusions and about risk adjustment, which are essential so that physicians feel like that they're not being held accountable for things over which they have no control. But buried in those exclusions and that risk adjustment are the reasons why global health and population health doesn't get better. So how do we keep these going on multiple fronts? We can't abandon the pressure that's on us for specific measures while we do the core measures, and yet we recognize that the core measures are not going to get us where we want to go at patient level, physician level performance.
Thank you for that question, and we'll ask each of our panelists to respond. And the question was insightful from one very important practical perspective in addition to the specific issue, and that is there are questions of this sort that the committee moving forward will have to consider. And they may be in your minds, and you may not want to get up and raise it in the public forum at this point, but please send them to us because it's very important that this kind of practical question that is vital for the application of whatever core metrics are proposed be before the committee in its work. Helen, do you want to take the first cut at this?
Sure, I think it's absolutely the issue that certainly I think many of us who live more on the healthcare side really struggled with at this meeting. Sure, it's great to have a set of measures that allow us to track our progress as a nation, but is it giving us what we need for those taking care of patients and frankly patients themselves to see the key processes or the key issues they want to see as they're taking care of themselves? So I think one thought is it can't be either or, it's got to be both. I do think having a core set of measures linked to a set of core data that I think Craig so beautifully described and Kevin really bolstered gets you a pretty far the way there. And I think the question is, how do we then take that core data set that will live in EHRs, we hope, across all of our systems and HIEs or whatever the case may be, and how do we link it to some of those clinical registries that are also being built up right now? And how do we prospectively work with registries to make sure they're being built on the data standards and the data infrastructure that allows them to come together, I would hope, over time with that core set of data that builds the core set. But you're absolutely right. It can't be either or. It's got to be both. But at the same time, though, we should also make sure even at the frontline provider level, we're really focusing in on the processes that actually drive the outcome. We've spent a lot of time measuring some things that actually don't move the needle. We've seen the data over time. And again, that burden is really important. It's time to really focus on the processes, those best practices that Kevin talked about that do move the needle, and abandon some of the measures that are adding burden but are not adding value. And I think by doing both of those things, we should hopefully make some progress towards accomplishing both those goals.
Thank you, Helen. David?
Well, one thing that confounds this is sometimes we don't make the distinction of a measurement for accountability versus improvement. And what freaks people out is that distinction often isn't made. So that's one issue right there. And it's not easy sometimes to separate. I don't mean that, but you got to call that out. The second, embedded in your comments, and also what Helen said is if there's a core metric we want to move, a provider or a health system is going to want to know what are some of the process measures and the key activities, and because they're going to work on it. And do we have that? And do we have the capacity? That means understanding quality improvement science, knowing how to do that, knowing how to test it, and some of the other things that many of you already know. But that is part of the infrastructure piece. So throwing up a core measure without, hey, these are some measures you could use at practice or system level to get this going. Here are some key activities or interventions that have been useful in other settings. Sometimes we have a lot of research, sometimes we don't, but that's it. And see what you can get started that way is really key companion to a core measurement set, or I think it will sit and not get anywhere.
Thank you, David. Kevin?
Yeah, this is got to hit this one head on. This is one of the kinds of key items for us to discuss. I totally agree. I think that a core measure set doesn't preclude a lot of other measurement that's key and important. To Helen's point, it's not either or, it's both and. And I think of one of the primary goals is really to decrease measurement burden. And partly we decrease burden by making measurement useful. Then what we're doing and what you're doing with measurement doesn't feel like a burden if you find utility in it. Even if it costs the same amount of investment for you, if you're getting a much bigger return, that means it's useful, and now it no longer has the same burden. I also think that this patient-centricness is one of the pathways through this question. So if I'm always asking myself as a provider, what's my contribution to this patient's overall goals for this year, then I'm measuring my additional value add to that patient's overall outcome. And maybe that's easiest to think about in a total cost of care for a patient and my particular contribution to it. But you could imagine a similar measure of health or health status. And I think that we have some creative ways that we can strive to do that, but it's going to require some change in how we all think. But the health system's asking us to do that anyway, to really be more team and less and more patient-centric.
Yes, please.
One other thing is about a feedback loop and be willing to change. I'll give you an example. When I was at HRSA, we were measuring PHQ, the depression scores, and the absolute number. And the providers were getting depressed themselves. They weren't seeing much movement in the absolute score. And what they suggested is, could you, because we know we're putting a lot of work in this, could you change it to the % improvement as opposed to the absolute score? And we did. And if you saw the run chart, you say, what happened? You know, we had to explain it, because we changed the measure. But what happened is that the folks that were working with patients on this started to see something from it. And we were asking a better question. So that shows there's a feedback loop, and there's a willing to alter measures when they make sense. So that adds a little bit more chaos, Kevin, into this. But I found that is really key, and I think we had a better measure for it.
Thank you, David. Yes, and then we'll go to Peter. And
hi, my name is Hassan Teta, cardiothoracic surgeon, doubling this year as a Robert Wood Johnson Health Policy Fellow. Kevin, and
IOM, Robert Wood Johnson
and
Health Policy Fellow.
That's right. And thank you for your hospitality, Dr. McGinnis. I have a question for the panel, but want to first thank Kevin for his visual of the dashboard and the pilot with the and all of the devices there. It reminds me of the care for heart failure patients. And in that practice, those of us that have taken care of heart failure patients, particularly in the recent buzz of the 30-day readmission rate and things like that, I've always looked at our heart failure patients as sort of their admission to the hospital and their readmission as not a failure of inpatient care, but a failure of outpatient care. In other words, the continuum of outpatient care for any patient, and I think congestive heart failure patients just highlight that and underscore that failure of outpatient care is sort of the problem. And in that context, the question I have for the panel is how do you all regard or think of a way of counting and measuring what actually counts, again, to quote you, Kevin, needing that feedback that's timely and useful. So that Mr. Johnson that's eating that extra hot dog out there before he gets readmitted to the ER with congestive heart failure and pulmonary edema, or forgot to take that Lasix, how do we get that early warning system, and how do we measure that moving forward? And that may not necessarily be the question for the next 3 to 5 years, but maybe perhaps beyond that. But how does the panel think about those aspects beyond measuring those things that are germane and that we have access to in the hospital and the nursing homes, but rather sort of all those other aspects that affect the patient's life on the outside that are going to impact their rehospitalization and hospitalization?
Kevin, would you like to take that?
Certainly. I mean, I can think about that in a number of different contexts, but I think one of the most eye-opening to me is I was talking to someone who spent their life as a process engineer in a factory and then was recruited to a hospital. And he said, wow, this place is not instrumented. How do these people know what they're doing? How do they see what's happening? Because they don't have any feedback. They don't know what's happening in a timely basis, and they can't get the information they need. And I think that's really what you're speaking to. Some of the really high-value organizations thinking about outpatient care of chronic diseases like heart failure have figured out how to do instrumentation of patients' homes with monitoring devices, and that feedback automatically goes into the system and alerts the patient, and it can alert members of the healthcare team, case managers, providers, others, when the patient may need an outreach intervention long before they actually reach a readmission point. So that's part of instrumenting and making electronic the healthcare system. And again, in a patient-centered way, what I mean by patient-centered is that it's not just that the hospital has access to that. Everybody along that continuum is going to need access to that information because they all have a part to play in helping that patient stay healthy and at home. And so figuring out that instrumentation is part of our job at the National Coordinator of Health IT. The measurement part of that is only a small portion. It's figuring out what the big roll-up number is that lets the health system decide this is important to invest in, that lets you compare one health system to another, that lets a patient make a choice about which place I want to go.
Thank you, Kevin. You want to take a crack too, David?
Oh, yeah. The first is I wouldn't think of inpatient versus outpatient. I would look at it as a system, and it's a failure of both. And you and I both, there are ways actually to deal with that. But the other is, I'm going to be low tech on the heart failure. Let's put instrumentation aside. Suppose we put our emphasis on patient self-management, and your patients had a scale at home, and they knew when to call. They didn't need the instrumentation. Now, you may go through a process, and there may be a segment of the of the heart failure patients who really do, because there's an issue about them able to do that. I'm sure that's true. But for the majority of patients, the system may work better if the patient learns how to, has that scale in their house, which is hopefully is accurate, and takes their weight every day. Low tech, plus you're building the efficacy of the patient. There's all kinds of really good, neat things about that. Other family members will see it. So I think that we shouldn't jump to technology. We ought, and I'm glad Kevin, I know he doesn't disagree with me, but it starts with the patient about what would really add value for the patient. And I think heart failure is a terrific example of that, if we can pull it off. And there will be patients that will need other interventions, I understand that. But I think that might be more effective in the long run, build patient efficacy, and also save money.
One very, very brief thought on that, because I agree completely with what they've said. I think the other thing is we need to increasingly value the voice of the patient in all of this. So the voice of the patient in expressing that I have symptoms that have changed or my function has changed is not something we've measured or valued. I had this just very brief experience on our ESRD committee a few years ago. We always have patients on our committees at NQF, and actually Lauren was the project officer. She was sitting right there at the time, although now Kevin has her. And the patients were having this whole, the doctors were getting really pointy-headed about hemoglobin levels and dialysis. And at one point, the patient just raised her hand and goes, I know exactly when my hemoglobin's less than 10. I feel it. And you guys have no idea that we feel it. And it was really one of those moments you think, and we have no way of capturing that information. So the more we get to the core measures that value to patients and providers, we'll start bringing in different sort of data streams about, I can recognize my symptoms in a way that creates a measure that you're responding to my warning signs rather than us just always responding to the technology.
Thank you, Helen. Valerie, do you have a web question?
Yes, this is from Alyssa Schuler-Adair at Consumer Reports, who asks, what are some examples of composite measures that have been useful and successful? One concern that might be had is that composite measures may not be as useful as individual items in certain circumstances.
Composite measures, a very important issue to deal with. Would someone like to take that on?
This is Kevin. I'm sure Helen has a lot more experience than I do, but I'll take on one as a participant. The state I come from in Minnesota has what's called the D5 measure, which is the perfect management of diabetes. And it's 5 things that every diabetic patient should be guaranteed of, which is their blood pressure is controlled, their diabetes is controlled, they're counseled about smoking cessation, they're on an aspirin if that's appropriate, and I'm forgetting the last one there, the non-smoking status. And so managing those things as a diabetic in the state, that was first really hard for providers to say, oh my God, this is so hard. How can I possibly do all these things? But it's really what matters in the end. You got to do the bundle of care, not just the individual item of care, to truly be delivering the right thing.
And I'll just briefly say, we've had a fair amount of experience with composite measures at NQF, and I think one of the key questions this person asked on the phone was useful and successful, and I guess I would sort of question to who. Composites are very useful for consumers and others and purchasers of care to see a more comprehensive view, but they're useful to clinicians and others when you can unpack them and see the results inside them as well. So I think we have to both be able to have the roll up as well as roll down, because frankly, there's different fit for purpose there. The roll down is really for the clinicians. The roll up is to get the more comprehensive view of care and compare ourselves and figure out how to improve.
I think the other thing from the practice side is if you have 5 composite members that are bundled, it tells you, do I actually have a system of care for my patients with diabetes? Because if I really have a system set up, I should be able to hit every single one of them. And that's a very useful conversation at the practice level. So I just wanted to add that as well.
Thank you. Modena?
Modena Wilson, Chief Health and Science Officer at the American Medical Association, and I wanted to respond to Mike's invitation to make a couple of comments from the AMA perspective or the AMA point of view, and then ask a question from my own public health background and interest. I think many things have been said here and are said in the workshop summary that ring very true to the perspective of physicians. A parsimonious set of outcomes measures that are of high value, matter both to patients and to physicians would be very welcome. We at the AMA have been intensely involved in measurement, convening the Physician Consortium for Performance Improvement. We've watched the number of process measures grow and grow, and I think focusing on outcomes measures, as we've been discussing, while still retaining those process measures to use as tools for performance improvement, is a very good way to think about this. The process of measurement should be a product of the system of care. It shouldn't be something that requires a lot of burdensome data entry, because that then becomes time taken away from time spent discussing behaviors and interventions with patients, getting their input. So much of what the workshop is recommending sounds very helpful. I think we also have to think about making sure that our measurement system will allow us to detect unintended consequences of what we're focusing on. And so that's something we often don't talk a great deal about, which I think is quite important. So I think there's much here to be very thoughtful about, and it allows us to adapt at the local level and innovate at the local level in a way that helps us really appropriately reach the outcomes we're looking for. Beyond that, I have a question about the extrinsic factors that you've mentioned briefly, but I think we have yet to really hear what kind of measures of extrinsic factors might be part of these data sets. How would we arrive at that portion of the set of measures, and how we're thinking about accountability around those types of outcomes measures. And I would really be very interested in the comments of the panel on the extrinsic factors that might be a part of this outcome set.
Thank you, Modena. As we go to any of the panelists who want to take that on, let me just give you a preview of the next 13 minutes, which is we're going to hear a question from Peter, and if Maggie wants to add a question or a comment, we would welcome that. And Bob, Jesse, do you mind if I ask you to offer a reflection on what would be most useful from the VA's perspective in the way of the development of core metrics for the VA system that would be reflective of the national interests. And then finally, we're going to give the last word to our panelists, and we'll ask each of them to give us, if they had one word of counsel to the committee and the IOM to make sure that the product of the consensus effort had the maximum utility and impact, what would that one word of counsel be? First, let's go to, pardon? Oh, yes, I'm sorry, extrinsic?
I can take this on, I guess. The work I did before I came here was research in health, in quality improvement in a safety net population, and we thought a lot about the social determinants of health and other things that were really key to high value health for patients that we saw. And we thought it was very important that what we did was understand the reasons for difference and then work hard to close those gaps, and sometimes with different interventions. So to my mind, what's important to measure is have a hypothesis about why you think something is different, and then to find a way to capture that information. So to put a finer point on it, we were looking at outcomes in our high utilizer population, and we found that 30% of them were marginally housed or homeless. And it wasn't until we started focusing in on issues around housing that we actually saw improvement in care quality outcomes. And we could have done all we wanted about compliance, adherence, any number of names, but it was truly a hierarchy of needs issue. And once they were stably housed, all of a sudden, all sorts of quality and utilization became much easier.
Thank you. David, did you want to add?
Yes, you asked us a little about how the work group dealt with this. And the way that we did, which I think was very creative, is divided the population health into current health, like mortality and morbidity, and future health, social determinants, so that they both could be captured and measured and worked on in the way that Kevin just mentioned. I think the other point that came up that's important in this is that communities and patients undergo enough of a health risk assessment, so we identify these things in the first place, and that they're recorded. So those are some of the things, the approaches that the group made during our discussions.
Thank you. Helen?
One very brief comment. I think the response I'd have there is those extrinsic factors, social determinants, whatever the case to be, are critical, and we know we need to measure them, but level of analysis matters. And I think when we start doing them at the clinician level, we kind of go off in the wrong direction. I think the key thing here is think about those at the population level and then begin to understand over time how those flow down into lower levels of aggregation where you can actually get buy-in. When people begin to see information on supermarket density in communities or fast food density, a lot of stuff starts to make sense, but it doesn't necessarily make sense to them at an accountability framework as an individual clinician in the way that it really can for a system or an ACO to start with.
So some measures might be core, but they should be reported only at certain levels. Peter.
So maybe to preview your final comments, what advice would you give to the committee around the equations? Because it seems if you start to move to payment, we've talked a lot about individual measures and using them, but when you move toward paying for value, you start to create equations between care, patient experience, health outcomes, and cost. What's your kind of guidance or thought of how the committee should think about that? I mean, there are lots of options for it, but just some guidance, because to me it seems like that's from performance improvement to accountability to actually paying for care under these core metrics.
The balance. Kevin?
I'll take a first stab. I would say that the payment should enhance systemness, and systemness and patient-centeredness is what I look for as a consumer. And so figuring out which ways that payment can enhance those two factors, I think, is the key. And that might be thinking about accountability differently than we think about it now. But that's my thought is systemness.
Thank you.
I'll just
Helen?
briefly
Okay.
respond, I think, similar to what I think I said earlier, that I think a lot of it really does depend on accountability at what level. So I think it is very logical to think about, for example, an all-cause harm measure at a certain system level that might be more difficult at lower levels of aggregation. So I think the key thing would be making sure you're actually getting a comprehensive view of care, but that the domains of what you're measuring should be logical for whatever the level of analysis is, and keep adding and adding more and more of that systemness for measures that reflect the system, I think, as opposed to individual providers.
Thank you. Maggie, did you have a comment or a question?
Both. I'm Maggie Carey. I'm the Director of Physician Leadership Development at VA, and Bob Jesse and I work together. So I have a question. I'm sort of struck here about the measurement thing. You know, as we at VA are all about measurement. But one of the things that I have a question for you, two things. One is, how do you train your people to want to do the right thing? Because the training we got in medical school is 180 degrees from playing in the sandbox, even as there is a whole bunch of literature showing that with good patient care, with teamwork, fewer patients die. The second thing is, I'm struck by the difference here from, say, XX in Health or Rock Health or any of the groups that are largely patient-driven, which are incredibly optimistic and forward-looking. And so I would ask you, and especially you, Kevin, I loved your comment on complex adaptive systems. I just hope we don't descend into chaos, cross the bridge into chaos. So I'm sort of curious, and Mike, you may have an idea, there may be other programs, but how do you bring that together for patient care?
Thank you. Kevin?
Training. So training is near and dear to my heart. I think that we need, quick aside, I was part of a research project by the National Board of Medical Examiners to have doctors self-reflect on data on their practice. The fascinating outcome that the 3 sites had was that doctors viewed data as a weapon. Almost across the board, they didn't have the experience of self-reflection based on data. They only had the experience of someone coming in with data as a cudgel and telling them they were doing poorly, and their only response was to be able to push back. And so I think that our job is to enroll the doctors into how to use data as a tool for improvement, which I think a lot of our registry partners have really shown us the way. And we need to learn from them and leverage the fantastic work they've done in those registries to figure out how to engage doctors to want, and all providers, to want the data, to use the data as a feedback in their system. And that's training the people that are in practice now. A lot of medical schools and a lot of residencies are now focusing on quality improvement as one of the core components of training. And I think we need to continue that in the graduate and undergraduate medical education as well.
Thank you.
Just briefly on I was going to make the same point about the registry piece, and the cardiac surgeons will know the work of STS, for example, of being able to show data surgeons believe that have driven significant improvement into the outcomes of cardiac surgery. And I wouldn't overstate how important it is, that line, data they believe. So I think the more we get to real data that people view as being clinically meaningful, patient meaningful, I think it'll be less of a sell than we might think.
Face validity matters.
Face validity matters, and we've been facing lots of years of people not buying the face validity of some of what comes to them, like this thing I got today, just meaningless. And so if there's something meaningful that actually seems to be logical that I can build into what I want to do to make care better, that's what everybody wants to do. Patients want to be better. Clinicians want to make patients better. And I think also if we get patients involved, if they're putting that data forward, I think it's also very different than just collecting it on clipboards in hospitals. There's something really palpably different about a patient reporting something to you than finding it in a chart.
Thank you, Helen. Bob, can we turn to you for your reflection on the VA?
I'll try and be brief, which is, is not one of my strong points. But I think when we look...
Julia has the microphone switch.
Okay. When we look at our system now, I think the reason you measure something is to improve on it. And that means that measurement has to be available to the person doing the work at the level where the improvement occurs. That being said, as we move upward through an organization, it has to be relevant across all layers of the organization. And so getting measures where we can do that then become the measurement, as was mentioned earlier, is transactional, meaning that if that data is important enough that you need it to manage the patient or the system, it needs to be accrued through the workflow process and not as a clipboard operation, because you can't improve when we're operating on a system that 6 months from now they're going to tell me what I did 6 months ago, and it's completely dissociated from the level of the work. And then the other thing is that in the VA, we set out many years ago to measure everything and improve and show that you can improve by measuring and following measurements. But performance, it seems to me, follows the rules of the Frank Starling curve, that if you drive the system too hard, you push it over the edge. And in fact, in a poorly performing system, managing the organization on a performance basis works. As we get more and more better, as we get better, perform better, then you have to be cautious and really begin to drive on a different equation, that is value. And so, you know, high-performing healthcare systems transition at some point from driving on performance to driving on value. And I think that recognizing where that occurs is really, really important for the eventual outcomes for both the patients and the system. So.
Thank you very much, Bob. Actually, those points are wonderful lead-ins to the final comments from our panelists. Just to remind, they're now going to give in a very brief fashion their one word of counsel to the committee and the Institute of Medicine to make sure that the product of the committee has the maximum utility impact. Which one of you would like to start? Helen?
B starts. One word of counsel, which is a bit paradoxical, is I think it's critical that the committee think about what matters going forward, but at the same time sweat the details so that you put out something actionable that can be used now. So I think there's got to be a path forward, but at the same time not lose sight of the future. But if we just put something out that's very future-oriented, we're still going to be stuck in the state we're in for way too long.
Thank you. David?
It's related to what Ellen said. Implementation strategy.
Implementation?
Yes. As best as you can with the position that you're in, because often what happens is people throw stuff over the fence and walk away. And I think that given what Craig and Peter said, people are actually very eager to take it on, but they're going to need a little bit of a help on the implementation strategy, and especially if we can set up a system of partnerships or collaborations to help people along the way, that would be fantastic.
Thank you. Kevin?
I'm going to borrow a little bit from our lean methodology, which is aim for the ideal state. So what we need from a group like the IOM is to tell us where the North Star is. But to these guys' point, we also need a future state. We need to know in 6 months, what is it we can actually get to in 6 months? And the specific counsel is we need this deep alignment, which is cross-measure alignment so that provider attribution is the same from measure A to measure B, not just agreement that we're all going to measure hypertension control.
Thank you very much, Kevin, and thanks to each of our panelists. Let's give them a hand of applause.